I'm just here now meeting with Jenny and Adam. It's Maria Westwell. I'm presenting today for the Society of Sports Therapists for the Communications Group. So Adam and Jenny have kindly offered their time to chat with us today to give us a background about themselves and their careers working with Connect Health. So thank you both for joining today. So Connect Health, a large independent provider of musculoskeletal physiotherapy, and yourselves are working within the NHS, is that right, Jenny?
Yeah, so I'm Jenny. I graduated back in 2017 from the University of Hertfordshire in sport therapy. Kind of my route to getting to where I am now was a lot of private clinical work as a sport therapist, focusing more like on hands-on treatment and rehabilitation. I was lucky that in my previous job I was put forward as a team leader, so I managed a group of clinicians, and then from that a job came up at Connect Health, which is what they label as an advanced MSK clinician. And yeah, I've been there for coming up to a year now, and I'm the same as Adam. We're both team leaders, so we each manage a small group of clinicians. And yeah, the Connect Health is exactly as you said. It's contracted by the NHS. We are a community service. The one that me and Adam work at is based in the Oxfordshire county. So we see kind of your regular day-to-day kind of people that maybe go to the GP with a back problem or because they've ruptured their Achilles or something, and then they get referred to us.
So Jenny, are you working in within like a hospital setting, a clinic setting, just so I can get a bit of an idea there?
Yeah, so around the county, there are I think about 9 or so different locations, and they're based either in hospitals or in like GP practices or small kind of clinical environments. So for myself, I'm based in south of the county, and I'm in a hospital, but it's kind of a small community hospital.
Great, thank you. And Adam, what about yourself? What's your background and degree?
So I am a graduate sports therapist. I graduated in 2014 with a degree from the University of Gloucestershire, and that's where I currently live and have my private clinic in as well. My background's slightly different to Jenny, so I've always worked in sport. So I started off at sort of community level and sort of recreational level sports. I then came back from the travelling scholarship with SST and then got a job at Hartpury College and University of Gloucester. They have sort of over, I think, 500 junior athletes from 16 all the way through to the professional teams with Gloucester Hartpury women and Hartpury Rugby, who are the men's team who play in the championship. I was the men's team rugby therapist for 4 years before, and during that time I was doing like all the long-term injuries, so ACLs and all that sort of stuff. At the same time. And then I got to last year, I saw the job come up at Connect, and then obviously through the SST I knew about what Connect was all about, and it was close enough to be interested in travelling across and being part of the new service there. And I thought for me it was almost like a change in career path. I needed something different. I've been doing sport for a long time. And to be honest, the sort of social side of working weekends and evenings was starting to become a little bit of a challenge, 8 into 9 years.
Which is always associated with sport, isn't it, in clinics?
Exactly. So I just needed something to freshen up, really. So it really appealed to me, that progression. So I was like, could go on to do a team leader role. And I was initially asked to interview for the same role as Jenny. And I actually decided to go for the more rehab side and the sort of more senior clinician role, which we will talk about in a sec, but that sort of matched what I wanted to get out of the job more than perhaps some of the other roles were offered. So that's my background. So I've come completely the opposite way. I've gone from sports, done all the sort of long-term stuff and all the advanced rehab, and and I had to change my style to fit into the service. Like I said, I'm a team leader as well, so I get to have some of that management experience too.
Okay, great. Thanks for that. Yeah, that'll be really interesting to hear a little bit more about that shortly. So obviously the Society of Sports Therapists were like really happy and delighted that Connect Health have sort of paved the way for empowering clinicians and therapists for their skills rather than their titles. So it's really sort of empowering now. Would you, Jenny, because obviously Adam's just touched on that then, just to get a little bit more of a background about you, Jenny, what got you working for Connect Health? Like, how did that sort of happen from finishing a degree? What kind of got you in that position?
Yeah, so similar to Adam, I started off by doing some sports, like working in sports teams. I found very quickly that I didn't like standing on a wet, cold football pitch. So went to a more clinical environment. I always found the title of being a sport therapist challenging. It's something which I've openly spoken about. Sport therapy versus physiotherapy. That's what always seems to be the hot topic. So I've always found it difficult going and working in private clinics, in a physiotherapy clinic, working alongside physiotherapists, doing the exact same role as the physiotherapist would do, but almost feeling very inferior with everything. So with pay, with
absolutely,
kind of how you're approached by the staff. So I was very lucky that I changed to a different clinic whereby I was much more valued in my role as a sport therapist, but I still felt very kind of inferior with different aspects. That's when I was a team leader.
Right,
so that's when I was a team leader in that role, as well as kind of your general day-to-day sport therapist, seeing kind of your general population. And off the back of that, I learned more management skills. I learned more how to kind of manage the patient as a whole. So my role within that was to kind of initially see the client and then filter them down to kind of relevant clinicians who have different skill sets. I moved house to a completely different location in the country, saw the advert for Connect Health. The advert was for an advanced MSK clinician, and it was on for brackets physiotherapy, osteopathy, and sport therapy. And what really caught my eye was that all of the different titles all had the exact same pay, all had the exact same benefits, all had the exact same criteria, just obviously the different relevant degrees. So obviously straight away, with the history of me feeling quite inferior, that was straight away what attracted me to Connect. So my role within Connect is, as Adam said, is slightly different. So you've got kind of what we call your tier 1 clinicians, which is what Adam is, whereby they see the everyday sort of patients for rehabilitation, for any relevant hands-on treatment, and like your rehab management. I'm a tier 2 clinician, so anyone who potentially is a little bit more complex, who potentially has failed physiotherapy, so is still really struggling, they come and see me, and I can then kind of assess them, work out if there's something a little bit more going on, maybe refer them for imaging or refer them on to secondary care. So that's more my role.
That's great.
When I first started the role, I was informed that for Connect Health, this was a new thing that they were implementing. And I was the first ever sport therapist in this role across what they knew in the country.
Amazing.
So it was pressure, but really
good. And I bet they never looked back as well.
No.
So Adam, if you could just give us a bit of an idea about what sort of types of clients you see and what conditions. So is it a certain sort of demographic you see, or a variety like you would sort of see in an everyday sort of a private clinic setting? If you could just give it an insight, please.
Yeah, so I guess it comes to maybe comparative to where I am now. My old situation would be 16 to 30-year-old active individuals who primary reason for coming to see me is because I can't play their sports. And almost flip that completely on its head, where majority of the caseload is probably about 50 years old. We may have more degenerative conditions that we look at, which joint-related problems or degenerative shoulder issues, for example. And also we have quite a high prevalence of acute or chronic low back pain. So you're doing a lot of managing of a person rather than dealing with just acute sports injuries, if you like. Obviously, from a sports therapy perspective, we're taught the same principles of musculoskeletal assessment, injury management, rehabilitation. The principles are the same, but it's just the application to the type of person and the condition that you see, which is key, I think, in this role, is understanding that you can't just apply the same brush to every person. You have to assess and take your time with each person and create a bit of a plan with that person. I think if you take it into the sort of private practice area, which is something I've started developing more finding, I think the difference sometimes is the adherence. So people maybe financially invest into a service versus have the service already sort of provided to them. Sometimes there's an adherence barrier to that when people pay for it. Generally,
absolutely, I could understand that. Yeah,
directly pay out of their pocket. I think sometimes there can be a little bit of friction there. So it's all about creating the buy-in for the person, understanding what they need to get back to. It can be something as simple as walking up the stairs, getting out of their car, getting out of their chair, or being able to dress themselves in the morning sometimes on really sort of difficult or post-traumatic cases. Having said that, we will still see maybe a younger cohort. We do see youth presentations. We have a pediatric specialist as well. So we do sometimes see younger patients up to, I think, the age of 8. And we may also see, we do see sports men and women come in too. Keen runners, swimmers, people who like to play recreational sports or have had sports injuries. So, you're basically going from quite a niche area sometimes to working in an NHS caseload, which is actually really can be quite varied. You just have to be ready for whatever walks through the door.
Sounds like a good variety of patients, though, and never a dull day. Jenny, would you be able to give us a bit of an idea why you feel that being from your sports therapy degree background, why does the sort of skills you learned during your degree, why does that make you suitable for what you're doing in your role now? Like you said, for example, when you applied for the job and it had sort of physio, therapy, osteopath, things like that. Why? What sort of skills that were sort of picked up in the degree make you suitable?
So I think initially it was something which I was really pushing myself towards. I would say, as Adam's touched on, all of the skills of like an injury assessment, all of the skills of really diving deep into the subjective history. I mean, I do that all day, every day with my clients. Although I am this advanced practitioner and although I kind of more guide my patients to where they need to be, I still heavily do like rehabilitation with them. So sometimes I might get a patient come to me from a tier 1 clinician, and I just put a little bit more input on some more specialized rehab. So for example, it might be from an osteopath or from a physiotherapist in this tier 1 level. And actually, I feel like my role as a sport therapist, I can add more specialized rehabilitation exercises to help them out instead of maybe just opting for an injection or for a scan, for example. So yeah, I think in general for the degree, kind of everything in terms of what we learn assessment wise, rehab wise, explaining to the patient, so kind of knowing your pathology and tissue healing, I use all the time. I think in terms of kind of maybe not what's learned, but what you pick up along the way, as Adam also touched on, with explanations, your communication to patients. As he said, it's very different working in an NHS environment, trying to get people to actually almost buy into what you're doing. A lot of people always come in, especially in my role, when they're like, oh, I just want an MRI, I just want an injection, I just want this operated on. So although
as
not
though it's a quick fix.
exactly, so it's just using everything that I was taught, and then also have learned throughout kind of my career so far in education and communication. It's massively helped with where I am today.
Oh, great, yeah, absolutely. Adam, I suppose with yourself coming from the background, your sports background, clinical background, did you find that you needed or received any sort of training to give you a bit of a background to the NHS, or sort of that type of setting before you started your role?
Well, obviously, you know, we was a brand new service. We started off, so it was very much everyone's in the same boat at the same time, and we had a caseload, and we was trusted to sort of deal with that straight away. But over the sort of last few months, we've been on a team leadership program, which has been really useful to build our soft skills and just get to learn our staff a bit better as well, which has been really beneficial. In regards to learning, you know, training specifically for the caseload, I think that's something I've just done by seeing patients. Obviously, we have an online academy which we can go into and allocate our own CPD. We get like 5% of our clinical time we actually get allocated to CPD. So it's on us to perhaps learn about certain presentations or pathologies, or shadow other clinicians, or spend time externally with other people if we want to. So the learning's on us to do that directly. We'll also run in-service training sessions, I think once a quarter. So, you know, there is training there to be done as part of that. And obviously, like I said, we have the induction process and the service introduction. But personally, a lot of my training has come from just dealing with the patients, understanding what they want. You know, we've seen a lot of patients per day, and you very quickly pick up on what maybe the patterns are, pattern recognition, pathology recognition, and then the best way to deal with those. I think one thing from my perspective was perhaps it was easy to be over prescriptive, coming from an environment where the person gets given stuff and they do it, and then they see you the next day, and that sort of loop keeps going till they're better, going to then a 6 weekly or 5 weekly turnover of appointments, and trying to be overly prescriptive, and that person either becoming confused, overloaded, or just reflexed, and then you end up back to square one. So I think personally that's something I learned quite quickly, and now get on top of that very swiftly, and to the point where things are progressing nicely. So I think you get a lot of introduction, you get a lot of time to yourself and build upon your skills that you already have, and there's a training modules available. But actually dealing with your caseload comes from understanding your basic knowledge, your basic principles, and seeing patients.
In terms of in terms of sort of that referral system and things like that. So obviously, like for myself in a clinical setting, if someone's self-funding as well, and you want them, you know, have an MRI, the process is you go to your GP, you might write a supporting letter asking for an MRI or to see a specific consultant, ideally like through the choose and book system. Is that different? Obviously, because when you've got your clinical head on and you've got your Connect Health head on, how does that differ? So, for example, would it be that you would then speak to someone like Jenny and say, I think there's something else that they need here?
Yeah, it's quite it's an ongoing topic in the sort of tiering system. Sometimes the tiering system almost gives you this idea that it has to be layers. You also see it when you work as a big team. That's the way I look at it.
Yeah.
Ultimately, you've got a patient in front of you. If clinically that person has exhausted all options, as in, you know, it's not going to get better with rehabilitation. Rehabilitation hasn't worked, and you've optimized that, or the presentation is getting worse. Ultimately, need to put them in front of someone who can make that change. So if it means that we then speak to another clinician who's in the tier 2, whether it's Jenny or one of the other team, we're starting to build that where it's, you know, we are a multidisciplinary team. So if it means I go and speak to someone who especially does a physio, who does, I know, low backs, I'll go call them. If Jenny's going to, I'll call Jenny if I've got some issues with her rehab, it's not quite working, but I don't think they necessarily need a scan. I might speak to her, and she may say, oh, yeah, we need to go ahead
Yeah.
and ultrasound, or we need to get a scan on this, or we need some further investigation. So it's very much on a case-by-case basis. Obviously, with different disciplines, there comes different thresholds for certain presentations. I might be on sort of the harsher side of the threshold, and some people may be more susceptible, just refer more. But that's part and parcel of being part of a team, right? Process, then if I did think someone needed an image or a further investigation, I would just refer to tier 2, and then I guess then tier 2 then deal with the assessment and triage of those cases, and then pass them on to the relevant service that's outside of Connect then to get that issue resolved.
Okay, great. Thank you for that. Yeah, it's just good to get a little bit of info just for myself to learn more about Connect L2. So Jenny, would you mind giving us an insight into a day in the life of? So would it be that you're sort of Monday to Friday, you have your set things, certain days, does that change? So just we have an idea of what it's like.
Yeah. Initially, I was just going to very quickly also say about my introduction, because mine was slightly different to Adam, and that plays into my everyday.
All right, yeah.
So I actually started a month before the Oxfordshire contract went live. So I was the only one within the contract. So I had kind of some specialist one-to-one. What I would say with the NHS, and I know that this is probably something that we're going to bring up later as well, it is this massive organisation. So as Adam was saying, although it may feel like we might be a bit harsh sometimes, there are a lot of hoops that we have to jump through in order to have things approved and in order for things to not be rejected. So my induction process was the same as Adam. We had this kind of intense week of learning the systems. Obviously, Connect Health has loads of different contracts across the country. So it was also making sure that we were aware of the demographic, but also the different pathways. Every kind of county have different pathways and different ways of doing things. So for example, like what you were asking, in Oxfordshire, if somebody was seeing a private therapist, so a sport therapist in a private clinic, and you recommended that they had an MRI scan, they didn't want to do that privately, they wanted to go through the NHS, the process would be they go to the GP and the GP refers to our service. In Oxfordshire, we act as like this buffer, because as we all probably know, the GP can be a bit trigger happy and send a lot of things on for orthopedic reviews when potentially it's not necessary. So we almost act as like a buffer. So that leads me on to my day in the service. I work Monday to Friday. The good thing about Connect is that they do allow for a lot of changing in your hours. So some people work a long 4-day week, some people work reduced hours, and they can pick and choose what time. So in terms of well-being, they're really, really good for that. So I work longer days, Monday to Thursday, and I only work a Friday morning at home, which is quite nice. My average day would be starting off with some management time. So within that management time, it would be dealing with any kind of queries or any diary changes that's potentially happened. So somebody calling in sick or there being a problem. I usually am kind of on call within that management time. So my team can reach out to me to discuss any cases, or kind of anyone across the business if they need to reach out to somebody to discuss cases or discuss any problems. In management time, we also carry out clinical supervision. So we are assigned like 5 clinicians and to aid in kind of their learning and progression. We usually do, I think it's per quarter, we have to do something like 6 to 8 hours of supervision with them. And that can be us observing them in the clinic and providing feedback, or it can be, which we find quite beneficial, as they'll see a client, we'll see one of their clients, and we do what's called a joint clinic. So we can provide feedback and show them how we would do some things. So that's really, really good. It kind of gives the clinicians a chance to not only learn from others, but also have that support all the time. Usually there's usually always some sort of team leader to talk through a case if there's a problem. My role is then seeing patients face to face, so usually 30-minute appointments. doing your normal kind of subjective objective. Mine is a very slightly different, whereby I will then kind of determine what have they had in the past. Okay, you've had physiotherapy input. How good has that physiotherapy been? Has it been appropriate? What is their health conditions? Could this be something else? Or where do we refer on? Referrals are usually done with like a letter. So I usually write quite a lot of letters after my clinics to wherever they need to go. And then the final part of my day is something called triaging. So I'll have a set amount of time whereby any referrals that come in either from the tier 1 team, so Adam, for example, or from the GPs, they all get put onto a triage list where we have to go through them. I think it's within 48 hours we have to have triaged them. So I will go in, I will look at what their GP has written, and then I will decide what is the relevant service. So do they need to come straight in to see someone at my level because it's maybe a bit more complex, or the GP's done some injections and they need to potentially be referred straight through? Is it someone who potentially has just got like a niggly Achilles and they need some physiotherapy? So that's another part of my day. So it's quite varied. It can be stressful at times, but it's very good.
It sounds like it's a good sort of, it's set up pretty well, like you say, to allow time for all those important parts of the role. And like you say, it does sound like they are really good sort of provider to work for, and they're quite keen on the wellness of the staff as well, it sounds like. So sounds like a positive environment.
I think it's also really good if you want to specialise. So what we haven't touched upon is all the other services that we offer. So there are kind of clinicians in my level who actually do injections. There are clinicians who specialise in what we call pain management. There are clinicians who specialise in paediatrics. So although we're coming in these kind of titles of tier 1 and tier 2, within that, using the CPD time that Adam's already spoken about, we could potentially go on and specialize and be niche in that area, and that be our kind of little area. Ultrasound scanning, things like that. So yeah, there's a lot of support.
It sounds great. And what about yourself, Adam? How would your sort of day-to-day vary from Jen's day-to-day?
I guess only not too much, a little bit. I mean, I too have the management time because I have a team. So a lot of my days are split with kind of chunks of different time. So I to do supervisions, like we already said. I'll do maybe another face-to-face clinic. So again, people come and see me, and that's generally on a Monday, Tuesday for me. Traveling over, I tend to do all my face-to-face clinics in one big hit. At tier 1, rather than having sort of triage, we'll have what we call physio lines. So we'll come from a triage list, and then we'll sort of go through those cases in a bit more detail over the phone. And that's where I like the flexibility. So I have reduced hours. So I work on a Wednesday, and I've come in on a Thursday on the telephone. So I'll do a lot of my management time and my telephone calls, which is basically understanding, is this patient needing a face-to-face, or do they need to be referred or not? If we can manage them remotely, we'll do that via our online applications with exercises and advice and guidance over the telephone, and then we can forward them from there. So my caseload is basically face-to-face half the week, phone calls with patients, and management time the other half of the week, basically. And with the flexibility of the role, then allows me to build upon some more local service. I have my private practice in Gloucester, so outside of the county, so it allows me to have that sort of that balance and avoid that conflict of interest, really. So that's been really nice for my quality of life, to be honest. Like I said, coming from sports, working 6 days a week, to then having reduced hours and flexibility within my working week, and then have a massive knock-on effect there. So I won't necessarily have the triage time, but going forward, having not I've gone directly into sort of tier 2 level, I've been working closely with some managers and mentors around potentially specialising in the rehab route eventually, when we have other facilities to provide that in the service. So at the moment, we're still starting off. We haven't got everything fully going yet. But once we get access to local gym facilities and gym studios and things, hopefully there'll be an advanced position that potentially could be a way to progress there. So it doesn't mean things just stop where we're at. You can always open up options as the demand within the service grows. So yeah, my day's not, it's half of maybe what Jenny does, and there's some other things slightly different.
Yeah, and it sounds great, like you say, it's a good juggle. You're still able to do your own private clinic stuff as well. So Adam, if we're looking at a sports therapist that was considering like looking for applying for work with Connect Health, is there any sort of tips that you would sort of help with? Like, do you feel that you need to have certain additional skills sort of post-grad to add to sort of applying for a role with Connect Health, or any sort of tips like that you could help with?
Yeah, cool. I've be brainstorming whilst we chatting. I think a few of the things that came to mind was, don't forget your uni PowerPoints, which had the pathologies on and your sort of typical, identification, risk factors and all this. Like, don't forget those. Like, super important to keep your knee osteoarthritis in mind. Your procedures for your post-op Achilles and your rotator cuff tears, degenerative shoulders. I'll be really clear what the protocols are for those. And don't forget about your healing times, your tissue healings. So that's a really good tool to use when you're speaking to patients, especially when they are looking for that quick fix that we talked about. Sometimes using healing time and understanding what tissues can react to certain loads, that's really useful to sort of explain to people. And keeping it really simple. Keeping it simple is the best way to deal with people who, I think, who are maybe always in pain or been in pain for a long time. And then when you keep it simple, your threshold testing and your understanding of that patient's outcomes and their plan, it becomes really clear. If you start overcomplicating it and trying to do long rehab programs and trying to be really specific on load, you're just going to get yourself in a tangle. I think keeping it simple, being really clear with the person, understand what they want to get out of each session and what they want to get out of it long term, and just make it really sort of specific to them, without going too mad with some of the exciting things we learn when we are.
Yeah, I think that's a great one to touch on, like the goal setting, isn't it? And obviously, like, just the education to the patient as well. If they understand what's going on, they're more likely to adhere to what you're doing and why you're doing it. Definitely. So yeah, they're really great tips. Thank you. Jenny, is there anything else that you feel you'd like to add to that?
So the exact same as Adam, in terms of making sure what you bring out of university. For me, I think with my experience in the sport therapy role, my only advice is keep pushing. Although we're sport therapists, we are not inferior. We need to just keep pushing for these roles. We are good enough. And it's communication, it's confidence, it's knowing exactly where we fit in and fitting in there. So for me, it's just keep yourself, you're a sport therapist, keep doing what you're doing, and all of these opportunities will open up.
Absolutely, yeah, that is key. I think sports therapist is understanding the value of our role and our degree, our education, our experience. Absolutely, yeah. Be proud.
Yeah, I think following on from that, like if you do back yourself and you do have the reputation of understanding things slightly different to other people, it's actually a really big selling point. When you start getting people coming down from a tier 2 or from an operation or from a physio line, and people are like, I know the person who you need to see because this is how you fit the pattern. And I do that to physios. I would say, look, this is kind of a little bit beyond where I feel my comfort zone is, and I can get some help with that. But I might feel like actually I might be experienced, but I think this particular profession might actually suit you a bit better. And I think that's important for us to work both ways, to say, look, yes, we are really good at what we do. We can do what you do. We just think a little bit different and we just apply things different. But at the same time, just knowing what our boundaries are sometimes can be really useful too. So yeah, I encourage people who do want to challenge themselves outside of a sports therapy setting or to traditional sports therapy setting to challenge themselves and get involved.
Brilliant. Thank you both so much. It's been really interesting for myself, and I suspect for members listening today, for you both taking the time out of your busy week. So I do thank you for that. So yeah, thank you, Jenny. Thank you, Adam.
Thank you.
Right, thank you very much.